Welcome. Today, we are discussing mucopolysaccharidosis, or MPS, a group of rare, lysosomal storage disorders. As pediatricians, we are often the first line of defense against these progressive, multisystem diseases. This blueprint is designed to give you high-yield insights into recognizing the early signs, executing the correct diagnostic workup, and initiating life-altering surveillance pathways before irreversible damage sets in. Let's start with the hard numbers. While individual MPS types are exceptionally rare, collectively they affect roughly 1 in 25,000 live births across more than 7 distinct enzyme deficiencies. The clinical reality is that MPS has an incredibly insidious onset. In infancy, symptoms are subtle, causing children to bounce between multiple specialists for isolated issues, like chronic ear infections or hernias, before a unifying diagnosis is made. Because these findings accumulate gradually across well-child visits, you, the primary care pediatrician, are uniquely positioned to spot the pattern early. Remember, our window of opportunity is narrow. Disease-modifying therapies are highly effective, but only if initiated before irreversible organ and tissue damage occurs. To understand why early action is critical, look at the cellular level. In a healthy cell, the lysosome acts as the recycling center, using specific hydrolase enzymes to break down glycosaminoglycans, or GAGs. In MPS, an inherited mutation impairs a specific enzyme. This creates a lysosomal bottleneck, leading to a massive accumulation of GAGs like dermatan, heparan, keratan, and chondroitin sulfates. As the lysosomes engorge, they disrupt cellular signaling and connective tissue structure. The result is a cascading, progressive multisystem collapse affecting the skeleton, airway, heart, eyes, ears, and brain. While all MPS types share a progressive somatic course, they differ markedly in their organ predominance and cognitive impact. For instance, MPS 1, 2, and 3 frequently present with severe central nervous system involvement and cognitive decline. Conversely, MPS 4, Morquio syndrome, and MPS 6, Maritose-Lamy, spares intelligence entirely, presenting instead with severe, predominant skeletal abnormalities. Also, keep a close eye on inheritance patterns. While most are autosomal recessive, MPS 2, Hunter syndrome, is uniquely X-linked recessive, predominantly affecting males. How do we catch this early? We map the red flags. Look for macrocephaly and frontal bossing, alongside progressive coarsening of facial features. In the eyes and ears, look for corneal clouding and unremitting, recurrent otitis media or sinusitis. In the oral cavity, note macroglossia and gum hypertrophy. Viscerally, look for hepatosplenomegaly and early onset, recurrent inguinal or umbilical hernias. Musculoskeletally, watch for joint stiffness, contractures, short stature with disproportion, and developmental delay. Here is your clinical pearl: 2 or more of these findings together, and specifically the triad of hernia, plus joint stiffness, plus coarsening features, is not bad luck. It is a pattern that should trigger immediate urine GAG testing. The musculoskeletal presentation is defined by dysostosis multiplex, a characteristic radiographic pattern featuring oar-shaped thick ribs, a J-shaped sella turcica, anterior vertebral beaking, and widened diaphyses. Clinically, progressive joint stiffness will manifest heavily in the fingers as a classic claw hand deformity, as well as stiffness in the elbows, shoulders, and hips. Crucially, beware of spinal involvement. There is a high risk of atlantoaxial instability, especially prominent in MPS 4 and thoracolumbokyphosis, both of which put patients at immediate risk for spinal cord compression. Finally, watch for peripheral neuropathy. Carpal tunnel syndrome is common but presents atypically in children. Screen with nerve conduction studies if you suspect it. Moving to the cardiopulmonary system, GAG deposition causes severe, progressive thickening of the mitral and aortic valves, leading to regurgitation. Restrictive lung disease develops due to thoracic cage deformities, compounded by recurrent respiratory infections driven by abnormally thick secretions. This brings us to the anesthesia danger zone. The combination of macroglossia, adenotonsillar hypertrophy, a stiff, narrow trachea, and compromised cardiac output makes routine intubation and sedation exceptionally hazardous. You must always flag a patient's suspected or confirmed MPS status before any sedation, imaging, or surgical procedure. Neurologically, our patients follow 2 distinct trajectories. Those with severe CNS phenotypes experience progressive cognitive decline, where behavioral changes often precede regression. They are also at high risk for communicating hydrocephalus and seizures. In attenuated phenotypes, intellect is preserved, but the risk shifts entirely to mechanical spinal cord compression from cervical instability. For sensory surveillance, arrange annual eye exams to monitor for corneal clouding, retinal degeneration, glaucoma, and papilledema from raised ICP. Maintain a low threshold for tympanostomy tubes given the high rate of mixed hearing loss, and closely monitor for obstructive sleep apnea. When you suspect MPS, navigate the diagnostic funnel sequentially and urgently. Step 1 is clinical suspicion, triggered by tracking growth, development, and multisystem patterns across well-child visits. Step 2 is your first-line check, a quantitative and qualitative urine GAG screening. Beware that false negatives can occur. If your suspicion remains high, do not stop there. Move to Step 3, the enzyme activity assay. This measures specific enzyme deficiencies in leukocytes, plasma, or dried blood spots to definitively pinpoint the MPS subtype. Finally, Step 4 is molecular genetic testing to identify the causative variants, which establishes prognosis, allows for family counseling, and qualifies patients for clinical trials. Management is highly active and dual-focused. First, systemic therapies. Enzyme replacement therapy, or ERT, provides weekly 4 infusions of recombinant enzymes. It is highly effective at improving somatic disease, but it does not cross the blood-brain barrier. For severe CNS phenotypes like classic Hurler syndrome, hematopoietic stem cell transplantation, or HSCT, is the standard of care. It must be performed early, ideally before 2 to 2.5 years of age, to introduce enzyme-producing cells into the central nervous system and preserve cognitive outcomes. Alongside these, we orchestrate continuous multidisciplinary care and targeted surgical interventions, from carpal tunnel releases to cervical spine stabilization. Once diagnosed, the patient requires a lifetime roadmap of structured surveillance. At baseline, obtain an echocardiogram, EKG, baseline brain, and full spine MRI, alongside comprehensive audiology and ophthalmology evaluations. Every 6 to 12 months, mandate regular cardiology follow-ups, hearing and vision screens, and close tracking of growth and joint range of motion. Annually, patients require a formal sleep study, pulmonary function testing, formal neurodevelopmentally testing, and crucial cervical spine flexion extension imaging to check for dynamic instability. Let's close with 6 clinical axioms to guide your practice. 1. Time is tissue. Early recognition fundamentally alters these children's life trajectories. 2. Trust the pattern. Hernias, joint stiffness, chronic infections, and changing facial features equal a unified syndrome, not a string of bad luck. 3. Screen fast. Confirm precisely. Start with urine gags, but confirm with enzyme panels and genetics. 4. Refer before the damage is done. Structural and advanced cognitive damage cannot be reversed by downstream therapies. 5. Build your multidisciplinary network early. This requires deep, lifelong coordination. 6. And finally, respect the airway. Never clear an MPS patient for sedation or anesthesia without explicit airway precautions. Thank you for your dedication to early detection.